The next talk is by Dr. Vishnuvardhan Reddy on assessing rheumatoid and its relevance in management. Dr. Vishnuvardhan Reddy is an upcoming rheumatologist. He graduated from Andhra Medical College, Visakhapatnam. He did his internal medicine from PGI Chandigarh and DM Clinical Immunology from SGPGI. He has been working in the field of rheumatology in the last few years and has been very active in the academic circles in rheumatology with poster presentations, publications. He was also awarded the first prize in rheumatology quiz at IRACON 2009, Jaipur, India. And he's currently working in Visakhapatnam. I'd like to request Dr. Vishnuvardhan Reddy to give his talk.
I'll manage from this. At the outset, I thank Dr. Chandrasekhar sir for giving this opportunity and the ChanRe team. This is my first visit to Bangalore. The introduction to this complex topic of measurements in rheumatology has been made easier by sir's talk. And this concept applies to almost all chronic rheumatic diseases. But coming to my part, assessing rheumatoid arthritis, its relevance in management. So I would first like to start. Lord Kelvin has long back given these words of wisdom. He said that when you can measure what you are speaking about and express in numbers, you know something about it. When you measure, you know only something. But when you cannot measure it and when you cannot express it in numbers, your knowledge is of a mere and unsatisfactory kind. This aptly applies to all fields, not only in physics or chemistry, but even in medicine also. So what I'll be talking today is why we need to measure in rheumatoid arthritis, what we need to measure, with what to measure, and how to use these measuring tools judiciously. So just to apprise of the new classification criteria, I will not go into much details because this is very important in appreciating the concept of measurements and why this new criteria is developed for rheumatoid arthritis. So the new ACR criteria is meant to pick up very early diseases and to treat as many cases as possible aggressively in earlier phases. So if you have more than score of 6, you classify it as a rheumatoid arthritis. It is not a diagnostic criteria, it is a classification criteria, but we often use it interchangeably. So why do you need to treat early and why do you need to measure all this? The whole concept of measurement is to catch and treat earlier actually. And why do you need? Because rheumatoid arthritis is not a benign disease. It is an aggressive disease. Here you can see these numbers vary from studies to study, but they are 2 times more likely to have myocardial infarction, CVA 70% more likely infections, increased risk of malignancies. The standardized mortality rate is 1.5 times. So this is the need to have, that is why we need to measure these diseases aggressively to prevent these complications. So now comes the target to treat concept. This is not new in medicine, but here what do you have in common in all of this? An LDL, a HbA1c, a blood pressure or a DAS 28. So all of you are aware of 1, 2 and 3 and are a little bit aware of DAS 28. These are all targets. These targets needs to be chased and they have to be achieved at any cost. So this is the concept of target to treat. So this is not new in medicine, we just borrowed from other fields of medicine. So you have a diabetes, for diabetes you have targets, for glycemic control as sir was saying, for LDL, only the 1 month, I think around 15-20 days back we got a new guideline saying that we should abandon the targets in LDL, but still that concept holds true. So the key principles here are, you have to detect early, you have to treat immediately, and you have to tailor the treatment to the individual. This concept of tailoring needs measurements. A tailor does measurements, and this concept of tailoring the treatment, it's not a one-time issue. You have to follow the patient longitudinally and tailor the treatment. This is called as target to treat. So So whatever guidelines you said, there are a lot of guidelines, ACR, ULAR, Indian, Canadian and all, any guidelines, the basic concept is same. You have to aggressively treat rheumatoid arthritis, and bulk of the disease progression usually occurs in the first 2 to 3 years actually. So the main treatment decisions incorporate the disease duration, the disease activity and features of poor prognosis. So I will be focusing on the disease activity today. So the goals of therapy for us are, we need a sustained remission, we need to prevent and arrest joint damage, we need to prevent or reverse the disability if at all, and to prevent collateral damage like osteoporosis or infections with the treatment. So there is a paradigm shift in RA management which comprises of early diagnosis, aggressive treatment and regular monitoring. So there are 4 overarching principles for. So the third and fourth are what we will be focusing today, the abrogation of inflammation by and target to treat by measuring disease activity, adjusting this therapy, that is called tailoring. So one measurement is worth 1,000 opinions. So why to measure rheumatoid arthritis? So way back in 1983 it was written, the clinicians may all too easily spend years writing doing well, continue same treatment. But at the end of 10 years, this so-called doing well patient will be having these deformities actually. Still he is doing well with deformities. He has adjusted his life to the deformities. So why we need to measure? To target it, we chase the target to get remission. To know the absolute state of the disease activity, you have to document the benefit of new or glamorous biological agents. You need a targets, you need remissions. And for that you need some values to showcase that. And not the least, for doing a cost benefit analysis for various purposes of insurance. These are the practical aspects actually. For these are the reasons also why we need a good measurements actually. So but how to measure and what would you measure? In rheumatoid arthritis, in hypertension you have a blood pressure, in diabetes you have a HbA1c. But in rheumatoid arthritis, there are so many measurements. How many measurements will measure? It's easier for a endocrinologist to measure a target to an RBS or HbA1c. For a nephrologist or a physician, it's easier to target hypertension by only measuring the blood pressure. But in rheumatoid arthritis, there is no single gold standard. So there are a whole host of targets actually. So we can't measure all the targets simultaneously. So what we have done is, cleverly, we have mixed these targets and made them into composite targets. So you will have only one digit or one figure which will include most of these actually. So you have to measure inflammation, you have to measure the disease activity, you have to measure the collateral damage, and you have to measure the function and quality of life in a single visit. It's not just measuring blood pressure or HbA1c. So all these 4 aspects you have to take, and you have to show it as a single digit or a single value. You can't have individual targets for each of these components in management of rheumatoid arthritis. So for this, the American College of Rheumatology has derived a core set, and they have told that these are the things you need to measure. So these are the targets, these are the measures you have to monitor. So swollen joint count, a tender joint count, acute phase reactants, either ESR or CRP, how much pain the patient is having, what is the physical function, what is the patient's assessment of global status, and what is your assessment of global status. So our duty is to measure all of these simultaneously actually. But now coming to each one of these, for a clinician, for a rheumatologist, looks like the most important thing is he deals with the joints. So we can't discount that, but it has its own limitations. They are poorly reproducible, they are more likely to improve with a placebo treatment, they are not sensitive unlike MRI or ultrasound, they are time consuming and tedious, and we just simply don't do for many of the patients. That is the biggest thing. Despite being a rheumatologist, in many patients we still follow that Wright's rule of doing well actually. We don't count the joints in the OPDs, in most OPDs also, in a busy OPD practice. So joint counts, there is a lot of inter-observer variability. So a rheumatologist who has a little bit of formal training counts the joints in a different fashion compared to a general physician or a family practitioner who also manages rheumatoid arthritis. So these joint counts, which are by different observers, cannot be compared reliably, and again the same person need to be documenting the joint count, and which is not practical. So this is some of the limitations. Again, sometimes after treatment you have a joint which was initially swollen, but now it is non-swollen and now non-tender. So you assume that the patient is not having a inflamed joint, but when you do ultrasound or an MRI with a normal looking joint and a rheumatoid arthritis, you can find inflammation. So that tender joint count which you take as 0, where you might really not reflect the underlying pathogenic process. Again, coming to the use of acute phase reactants, which will be dealt in detail later by ma'am, but however, to your surprise, at least 30% of patients will have a normal ESR or a CRP during the initial phase of rheumatoid arthritis. That is the time period when we need to aggressively diagnose and manage rheumatoid arthritis, 30%. And ESR and CRP are not specific, but there are many entities which can cause elevated ESR and CRP, and we sometimes it's very difficult to ascribe whether the ESR and elevated CRP are due to primary rheumatic disease or due to a coexisting condition. There are different methods to measure ESR and CRP. So when you go out in practice, you see a host of reports where one person will be doing by automated method ESR, another will be, even the simple ESR is not standardized. So how will you use this ESR and CRP? And again, many a time the CRP will be written as negative and positive actually. But when you want to use a ideal measure, composite indices, where even in lower CRP is given a specific amount of weightage in the scores actually. So just telling that CRP is negative will not help. So these are some of the limitations of the current laboratory tests. And to add more confusion, so we always wonder how much ESR is corresponding to CRP. Some cases the ESR will be elevated, but CRP will be normal actually. But this is what the ACR has said. In men, a CRP is equal 1 milligram % is equal to roughly 20, and in women that correspond to around 30 mm in the first hour. So again, many a times we don't get investigations when the patient comes. So they will be having ESR of around 2 to 3 months previous actually. The CRP might not be immediately available, although nowadays with the current rheumatological practice this is being avoided, but it has shown that even if you have an ESR of 3 months older ESR, it will not usually affect your management unless the patient has a severe change in the functional status or tender or swollen joint count. So sometimes, so this shows a 3-month old ESR is as good as a present ESR also. So there is a lot of limitations actually. Again, once the ESR is controlled and it has gone to a certain level, even though the patient is doing well, the ESR will not come down. So the patient is doing well, the ESR will not come down, and your DAS score will be always higher. And according to the target to treat principle, because the DAS is higher, you have to increase the methotrexate dose. But patient says, doctor, I am fine. Why are you trying to increase my methotrexate dose? So the ESR will not really reflect the real underlying physical condition or the pathological condition of the patient. So these are some of the inherent limitations of using these. And to add more confusion, so more and more literature is coming, and now they say that even acute phase reactants add little to the DAS score actually, to the changes in the DAS score. So we leave that ESR confusion there, and coming to, when we want to avoid this, we resort to patient reported measures. There are so many measures like patient reported measures. So nowadays the bulk of the onus of giving the functional status is being shifted to the patient. It is said that patients will give their better status of their disease activity compared to our interpretations. However, there are again some difficulties. The patient questionnaires are not specific to the degree of the inflammatory activity. Gender differences are obvious. Normative values, I will just come to this. And there are cultural differences, and the motivation of the patients in filling the simple questionnaire is also doubtful. So this is called modified hack actually. So this is one we usually use. So how to score hack, that Dr. Dharmanand will be speaking in the next, but just to give you an idea, This is one important outcome measure in rheumatic diseases, in all rheumatic diseases. Here you can see, to just give you an estimate of how much important this modified Hack score is, if you compare this with rheumatoid factor, even a modified, it predicts the mortality better than a rheumatoid factor. Even if you have a rheumatoid factor or positive or negative, it doesn't matter. But if you have your Hack score decreasing, your mortality is also Hack score increasing, the mortality increases actually. So this shows what is the importance of functional status. However, there are some limitations to this. So some patients, chronic low back pain is a very common condition, widely prevalent in general population. Fibromyalgia again. So if you have patients with this rheumatoid arthritis with low back pain and this fibromyalgias, then the patient obviously, despite however well you control the inflammation, still he will give a functional score, a modified Hack score will come bad actually. So these are some of the limitations. So despite you adequately treat the disease, if you use these patient reported outcomes, they will say that doctor, still even if you give the best of the biologics, still they will end up in telling that my functional status is low actually. So these are some of the limitations. So again, this is 30-year-old man and his Hack is 1 with rheumatoid arthritis. And for a 70-year-old man, again the Hack is 1. So would that mean that the level of disability was same for the both? For a 30-year-old man and a 70-year-old man, the score will come like similar. But that does mean that it is the same disability. So these are some of the inherent limitations actually. So there are some cultural differences regarding with the education and all. And again, even if you have joint counts improving, you can see the disability actually. Over a long term, the true tender joint count or swollen joint count after 5 to 6 years of treatment, here you can see on the to the right of this, the tender joint counts and swollen joint count improved, but his joint count measures are improving, but the disability and the damage scores are getting worsened actually for the long term. So this shows there is a lot of disconnect between the tender joint count, swollen joint count, what we routinely do, what we emphasize in acute phase reactants in DAS, and the patient outcomes after 5 or 10 years actually. So for this they have developed a lot of indices. The first one was the ACR indices actually. So this was the definition. So they used to tell ACR 20, 50 and 70, and if you have improvement in joint counts and improvement in 3 of the underlying assessment, physician assessment, ESR, pain scale and functional. So that is how they used to see. So here I will show you a simple example. A 25-year-old female with a 3 years rheumatoid arthritis, she has come with a tender joint count of 25, swollen joint count of 20, ESR of 100, shows that she is a very poorly managed case on only 7.5 milligram methotrexate per week. So she came to you, over the next 2 months you hiked the methotrexate to 25 milligrams parenteral. So after 2 months her tender joint count is 5 and swollen joint count is 4 and ESR has dropped down. According to the American College of Rheumatology definition, this case has ACR 70 response. So you can appreciate that 25 tender joints and it has reduced to only around 5, roughly 70. So with a patient of ACR 70, according to ACR, it is a good success even for any biological agent evaluation. But is this a success for our clinicians? Now you have a patient in your OPD sitting with 5 tender joints and 4 swollen joints. How can you call this as a success? So this is one major limitation. So these criteria were now discarded. So ACR criteria measure only change compared to the baseline, but not to the absolute status. So now we have come with newer modifications of these measurement called the composite indices. So now when you measure the disease activity, will it lead to the less disease activity? Yes, there are important trials which I have shown. I will not go into this. But the best use of DMARDs is by protocol driven associated with continuous monitoring of these composite indices. So there is various studies like TICORA. So here you can see when we do intensive care, your response and remissions are far better compared to the routine care without using measurements. So but how will this trial data be applied to our patients? You read lot of trials in the journals, but can we apply this into our patients? You have to remember these trials are based on patients with more active disease. Again, to be in trial, the patient should have at least 5 to 6 tender joints. The biological companies or the newer drug companies will not take patients with low disease activity. Otherwise, how will they show difference? Only if the patient has severe disease activity, high disease activity, it is easier for them to show a benefit in the patient. If you already have a low disease, the newer drug companies or trials, it's very difficult to show the benefit actually, even though the drug is working. And also most of the patients seen in clinics, they don't, because they have too little disease activity. So it is well documented fact that trials what we read are different from our clinical practice, and these include only high disease activity patients, and the long term follow up the patients in the trials again is selective. But now when we come to the clinic, we have to use this target to treat strategy what we are proposing now. So this is a gross flow chart, but I would like to simplify this by this. So it's a little bit complex for non-rheumatologist, but see here you can see this is a simpler version. You have an active disease, you measure the disease activity by whatever measure you want. There are so many measures, every 1 to 3 months or at least 6 months sometimes, 3 to 6 months. If your target is achieved, yes, continue the same treatment, but if your target is not reached, then you have to hike up the management. This is the crux of target to treat. So when is this strategy feasible in clinical practice? Yes, they have shown that it is feasible in clinical practice. So now coming back to again to the 7 measures what the ACR has proposed, which we need to measure. So these are the 7, and now we have these indices, composite indices. So I'll make it a little bit more palatable. Now this is these are the same measures. So this is the patient only. So the patient will be giving what is his disease activity. There will be no involvement of you in that. Again, the CDI, which includes the patient and provider data, and the patient, provider and the lab data. So these are some indices called DAS28 and SDI actually. So how have these evolved actually? This is initially it will be a little bit confusing, but I will just tell. So initially DAS28 DAS has come, then it has followed by DAS28. I will not go into those nitty-gritty details, but so this is it. You can see the very complex formula of how to calculate the DAS28. You need a computer actually, you need a laptop, or nowadays we have applications in your smartphones, and this is the complex formula actually. We doctors are usually very poor mathematicians, so we use this, and here it includes the swollen joint count, the tender joint count, the ESR and the visual activity score. But now, because then we complained that we can't calculate every day actually. So what they have did, they have removed that. They have removed that calculation part and they have converted into SDI actually. So now it has tender joint count, no calculation business, complex calculation business, the tender joint, swollen joint, CRP, and your global assessment and the patient global assessment. It's just simply summing it up. So then still we are lazy actually. Then we told that CRP is not always available. So we have removed the CRP also. So sometimes the patients will not get the CRP done. So then what we have subtracted the CRP from SDI, it has become CDI actually, clinical disease activity index. So this doesn't have a CRP or ESR, so we have only the global assessment of the patient and the doctor and the tender joint count or a swollen joint count. So I'm just made this to just you appreciate how this has evolved actually. So when you read in the textbook, you will have DAS28, SDI, CDI, scores, blah 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 blah. But this is how it has evolved. Why SDI has come? Because CRP is not always available, because DAS28 you can't calculate. Why CDI has come? Because we can't get the lab reports immediately many a times. So there are different scenarios. To give an estimate, if you have a 8 tender or swollen joint counts with the ESR around 50, you will have this high ESR actually, and 4 and all. So as the number of tender and swollen joints decrease, the DAS will decrease proportionately. There is a different weightage. In a DAS28 score, despite having 4 components, all of these components don't weigh equally. So if the highest number is by the tender and swollen joint counts actually. So if you have more swollen joint counts, then the DAS will increase disproportionately more than the tender joint counts actually. So just to compare this, so in a DAS, it's a simple count, but however you need this calculatory part, and CDI and SDI where you use this visual analog score of 0 to 10. So higher, it's a continuous score actually. So in the DAS it will be somewhere around 0.49 to 9, and in CDI it is 0 to CDI it is 0 to 76, and in SDI it is 0.1 to 86 actually. But here you see which of these is better then. You have SDI, CDI, DAS. Nowadays calculation is not a big problem for us. So now now we have to find out the limitations. Sometimes you can achieve the DAS remission by, according to the textbook definition of less than 2.4, you can get a DAS remission on paper. But here you can see DAS will not evaluate the foot joints. Many of the rheumatoid patients will have arthritis in the foot joints, which this famous DAS score will not evaluate. So the foot is completely ignored in DAS 28 actually. So you can have a rheumatoid arthritis patient with foot arthritis. So here you can see, even with good DAS for remissions, you can still have some joints involved. So simply having remission does not mean that you have no swollen or tender joints. Even with a remission by DAS, you can have up to 9 swollen and tender joints combinedly actually. How can you call a patient with 9 joints as a patient in remission? You have a DAS score in remission, but still the patient is having 5 to 9 joints swollen and tender. How is that possible? So, this is the biggest limitation of DAS 28, the failure to assess foot involvement, and this might lead to the treatment that is less intensive actually. So, which is the most stringent definition? So, here you can see, so DAS score with even with remission you can have up to 9 joints. But if you use this SDI and CDI, only 1 or 2 joints will be swollen at the max, even if in the page during remission phase. So for us, the most stringent criteria is the SDI and CDI right now. So because of this, the ACR for using the definition of remission in practice, for measuring the disease activity and remission in practice, it has used the CDI less than 2.8. So which tool to use in clinical practice? ACR says any tool you can use, any one which you can use to measure anything. ULR says they didn't say anything at all. The target to treat, you have to see if you are having some comorbid condition like ESR actually. You can't use if some patient is having a tuberculosis with rheumatoid arthritis. Because of tuberculosis also ESR can increase. So you can't use DAS in that. So you have to use the CDI actually. So you have to adjust. It's not like there is no rigid recommendation that you have to use such and such measurement tool actually. Again, how is it different from treating diabetes or hypertension? It is very difficult to evaluate the effect of treatment. Just because you have hiked up the rheumatoid arthritis management, it's not that the tender joint or swollen joint will come down. So sometimes it will take months, 2 to 3 months also for your effect to be shown in the patient. Again, until the desired, patients also sometimes don't like to change the treatment every 3 months just because their DAS score or CDI has not come to the target actually. These are some of the limitations actually. But however, these are the important barriers. Like I said, they're not, sometimes patients are reluctant, and if you make the patients involved in treatment decision making process, sometimes it's a big barrier to change the treatments, and the expense, sometimes you can't get the achieved remission targets only with the DMARDs because of cost involved in the biological agents. So for the long term RA, we should be content with a low disease activity. And again, coming to which tool, you have so many tools. If you don't know how to use, you can never use any tool actually. There will be so many tools. So the take home messages are, you should pick up one tool, be acquainted with that, use it consistently. It's better to have something rather than nothing. And please remember, if you have DAS less than 2.4, it is not equal to real remission actually. And again, SDI and CDI are more stringent and easy to measure. Thank you.
Thank you, Dr. Vishnuvardhan. Dr. Dharmanand?
Nice talk, Dr. Vishnu. Which is a measure you find it useful in your clinic?
Sir, I use DAS. I regularly use DAS actually. DAS 28, CRP1. The ESR one, again in DAS there are variants of DAS for the general audience. The CRP1 is more validated actually compared to the DAS ESR 4 variables.
Thank you.
Dr. Pradeep?
Thanks for the very useful talk. I just want to comment saying that like the assessment process itself, it's the frequency of visits which the patient has with the physician that's also important. In this assessment, that is something, it's a hidden factor. So the reason why, when even Dr. Chandrasekhar said the academicians, there's a difference between them and the clinical practice, it's just a frequency of visit. Even the Ticora trial, that's what it is.
Yeah.
So it's seeing the patients frequently and assessing them is equally important to the process of assessment as well.
Yes.
So I think
yes.
that needs to be taken into account.
Yes, because
Thank you.
yeah, well said actually, because sometimes patients will come frequently because for a change in symptoms actually, but the real scores might not really change actually. See, even if the scores are not changing also, dependent on the patient's symptoms, we have to adjust the treatment, titrate the treatment. Only then we will get the desired so-called remission actually. What the remission what we are speaking might be true remission, not be true remission, but this is what we have, and so at least whatever is available, we have to target that remission available.
Thank you.
If there are no more questions, I'd like to thank Dr.